Good evening, everybody, and welcome to Ask the Expert. Before we get started, I would like to give a little housekeeping rules as we go through how you can participate in tonight's webinar. So first, we're going to have the chat feature. If you're interested in just dropping general comments or statements, please use the chat feature. If you're interested in asking a question directly to our speaker, please use the Q&A feature. And don't worry about that polls. There will be no polls for this particular webinar. And we'd love to hear from you. So please stick around. Once you exit the webinar, please click the survey. There'll be a survey that pops up in the same field that says the Zoom review. And if you can please click continue and take a brief survey, that will be about 7 questions. We would greatly appreciate it. And tonight I would like to welcome our guest speaker, Dr. Javier Bolanos Meade. Dr. Javier Bolanos Meade is a distinguished medical oncologist, oncology specialist based in Baltimore, Maryland, here at Johns Hopkins University. He graduated with honors from Tecnológico de Monterrey and subsequently pursued his medical education at Texas Tech University Health Sciences Center, as well as the University of Maryland and Johns Hopkins Schools of Medicine. With over 30 years of diverse experience, particularly in medical oncology and internal medicine, Dr. Bolanos Meade has been affiliated with Johns Hopkins Hospital for the past 20 years and the university, where he engages in cutting-edge research while mentoring and the next generation of physicians. Please help me welcome Dr. Javier Bolanos Meade. Dr. Meade, how are you this evening?
Well, I'm very humbled by the introduction, but well, thank you.
We appreciate
Thank you very much for the invitation.
Oh, thank you for being here. We appreciate your time taking out to speak with us, specifically tonight about blood cancers. I think this is a cancer that not many people pay too much attention about. We hear about breast cancer, we hear about colon cancer and prostate cancer, but I don't think we take time to really dive into blood cancer and what are their risks and what that looks like. So I'm excited to have a conversation with you this evening. So before we get started, I'd love to hear a fun fact about you, something that is not related to medicine that you wouldn't mind sharing with our audience.
Fun fact.
Just put you on the spot.
You did indeed. Let's see. Fun fact. What could be a fun fact? Believe it or not, I'm a rock climber. I think that's a fun fact.
It is.
It's not particularly popular in Maryland because we lack really mountains here. So it requires some traveling, but that's maybe a fun fact.
Yeah. Do you have a favorite mountain that you've climbed so far in your life?
Oh, So I have a favorite mountain that I need to go back. It's a volcano outside of Mexico City called Iztaccíhuatl, in which the last time I went there to climb it, we got trapped in a snowstorm.
Oh no!
And it was it was not particularly fun.
I see why you would want to go
back.
It
was quite a miserable night that we had to spend in the mountain, freezing with terrible winds and lots of snow, and and we couldn't
I
go
can
up.
only imagine.
So that's a mountain that is on my list to go back.
Oh, I love it. Thanks for sharing that fun fact with us. I really appreciate you giving us a dive into your personal life. We appreciate you.
Yeah.
So as we get started to discuss blood cancers, can you start by giving us an overview of what blood cancer is and why is it crucial for the community to be informed about blood cancers?
Sure. So blood cancer is a group of different diseases that go from some of them very common to others very rare, that affect not a lot of Americans. So the reason why they're not necessarily as popular as breast cancer or colon cancer is because they're just number-wise very rare. However, some of these blood cancers are actually increasing in number. Um, so there's in the different types of blood cancers that we have, one of them called lymphoma. Lymphoma is one of the diseases that we're seeing more and more cases every year. And so some of these diseases are increasing in number, though it's still relatively rare. And perhaps the most important reason for people to keep them in mind, though I don't recommend anybody to be thinking about this 24/7, is the fact that when these diseases present, usually patients are very, very ill. So these are people that have been sick for weeks or months, and they can't figure out what's going on, and they go and they see the doctor, and until eventually the doctor orders the test or the 20th round of test, because they usually go from the common to the least common, and then they say, oh, there's something wrong here. So even when they're not terribly common compared to other cancers, they make people very, very ill.
So you mentioned that the people are ill and they kind of really don't know what's going on. So what are some of the early signs and symptoms of blood cancer that we should be aware of?
So the symptoms are incredibly vague, and that's one of the problems, right? So people start losing weight, people start getting fatigue. So you have the patient who used to go to the gym 3 times a week, and right now just going from the couch to the kitchen is an act of Congress. So those are the things, right? People are just slowly losing their energy, losing weight, not eating right. They get pale. And then there may be other manifestations depending on the specific blood cancer, but these issues are very common to almost all of them, right? Weight loss, fatigue, lack of energy, lack of appetite.
Now, are there anything, because they're so vague, is there any indication or anything that I could, not nudge my doctor to do that testing earlier on rather than waiting for like the 20th round of testing?
Well, yeah, so not really. And the reason for this is if I were to list the things that make you lose weight when you are sick, I will list 100 things that are more common than blood cancers. So going to chase for a specific type of blood cancer early on in the medical visits will just add a lot of stress on you, because the overwhelming majority of patients will not have a blood cancer. Right. So, for instance, it's much more common in our community for people to develop diabetes, way more common than blood cancer. And diabetes will give you weight loss, will give you fatigue. For instance, the flu will make you lose weight and make you fatigue and not being able to eat, even if the case of the flu is going to be usually more acute. But the type of medical problems that will give you these symptoms are way more common than a blood cancer. So it's not necessarily something that you want to be chasing early on, because the chances are that's just not what it is.
Got it. Okay. And so with that being said, if on the air of caution, are there any screening tests to identify blood cancer before I reach the point of feeling symptoms? And if not, do you foresee any testing in the future?
Well, yes and no. So there's some there are no official recommendations for screening for blood cancers, right? So contrary to breast, in which you can go to the doctor and say, well, it's time for my mammogram, and then you can have one, or it's time for my colonoscopy, for example. We don't have anything like that in blood cancers. Now, that said, there's certainly some testing that can make you think as physician that there is something wrong that needs to be further investigated. Right? So if you have a patient who presents with anemia for no reason, anemia is a disease in which you have low blood counts. And if you have anemia for no good reason, well, that will make you think that maybe something wrong with the blood. On the other hand, if you go with the doctor and you say, um, I'm losing weight, and the other day I was in the shower and I noticed a lump somewhere in my body, and you show it to your doctor. That's not very specific for for blood cancer, but it's very specific. It's very suggestive of cancer in general, and a lot of blood cancers can give you lumps. So if you have a lump, well, yeah, that's something that needs to be investigated. Now, this is important because when people think of blood, people think of the red stuff that is inside the veins,
Yeah.
which for sure is blood. But the blood, our blood has an extravascular component, if you will. So there's a lot of blood that is not inside the blood vessels, and is not red and is not liquid. So the lymph nodes that we have, the glands that we have in the neck, for instance, that when you have a sore throat, they get swollen, but that's blood. Even when people don't think as such, but it's just blood. So when you have a swollen gland, there's a good chance that there's something that is happening to your blood system that is making this swollen. Now, the majority of cases of swollen glands are actually infections; they're not cancer. But those type of things you can go and tell your doctor. But we don't have a screening test in general. Now, there are some screening tests that are being proposed for evaluation. So, but this takes time before they get to be confirmed or so. So it really is. These diseases usually present when the patient is sick, goes to the doctor, and either by luck or by the 20th time that they do tests, they just do the right test and say, "Oh, there's something wrong here."
There's something wrong. So there's no particular screening test, and I don't have symptoms, but is there a particular family history or a genetic component that comes along with blood cancer?
Oh, yes. So again, and I'm just using breast as an example because breast seems to be a very popular disease in terms of the community knowing about it. There are certainly some breast cancers that can be linked into families, right?
Right.
In blood cancers, there are some families in which it's known that they have a high incidence of a given disease, to the point in which you can detect the clusters, but there is very little information regarding familial, really genetic cases of blood cancer in which you inherit the disease. I remember about 15 or 18 years ago, I was involved in the caring of a family in which several siblings of the family had leukemia, which is a form of blood cancer. And they actually were found to have a specific gene. But that was one example in 20 years of practice, right? The majority of cases of blood cancers are sporadic. That is, the patient shows out of the blue, and that's it. Now, there are some blood cancers that are relatively common as we age. Just like, for instance, prostate cancer, which is not a form of blood cancer, but prostate cancer tends to be more common as we advance in age. There are some forms of blood cancer that are also more common as we get older. And it's not uncommon to see few members in the family that have one of these diseases. And it's very difficult to really blame it on the familial component because they get to be common as we age. So there's a form of blood cancer called chronic lymphocytic leukemia, which is the most common form of leukemia. And perhaps it's not very famous because in the majority of cases, it really doesn't make people very sick. That's not true for everyone. But there are a lot of people with chronic lymphocytic leukemia that are walking around that they don't even know have the disease and they're happy. But this is a disease that we commonly see in people that are in their 70s or 80s. And it's very difficult to really blame this on a genetic component because we're just aging. But there are some few family clusters that have been detected on certain families, but it is not, as of right now, we don't have a gene that we can say, oh, if your parents have it and you have it, well, your parents will have the disease, you will have the disease. We don't have.
Well, are there any other like risk factors? And if it's not genetics, I heard aging, but are there any other risk factors associated with?
Sure. Oh, yes. So radiation exposure is a big one. After the attacks on Hiroshima and Nagasaki at the end of World War II, the rates of blood cancer between survivors were incredibly high. We know that. We know that people who were exposed to radiation early in the 20th century, when they were developing X-rays, developing the X-ray technology and so on, it was not entirely uncommon to see patients who eventually develop blood cancers. Chemical exposures. So for people who work with certain chemicals, I'm not talking about things that you usually have at home, though.
Okay.
But people who really work in laboratories or work with painting manufacturing, those people tend to have the exposures that are increase the risk of cancer. Agent Orange, who was heavily used during the Vietnam War, has been linked to the development of certain blood cancers. HIV infection, for sure, people who live with HIV have a much higher risk of development of certain cancers. And it's one of the reasons why lymphoma that we were talking about a few minutes ago is becoming more and more common, is because there are more people with HIV and they are living longer. It's not necessarily the only disease that we say people with HIV, but HIV certainly increases the risk of developing blood cancers. And that's a problem because Baltimore is a place in which there is a high number of people with the infection. So yes, people who have immunodeficiencies for other reasons different from HIV. So people who receive a kidney transplant or a liver transplant or any form of transplantation, and they have to be on immunosuppression. And people who have autoimmune diseases and then they take immunosuppression, that also increases the risk of blood cancer. So yeah, there are a lot of things that you can do to increase your risk of catching one of these diseases.
Seems like it.
Yet
Wow.
they is still very uncommon. Just want to stress that this is despite all this, the thing is, if you have, I don't know, 1,000 people with HIV and you compare to 1,000 people with HIV, the risk in the HIV population will be higher, but they still are a low number.
Low number. It's still pretty rare. That's understandable. And so let's say we have a patient. Could you walk us through what the diagnostic process looks like for somebody who's showing symptoms of blood cancer?
Yeah, so there are different types of blood cancer, so these will require like different stories. But so again, commonly the patient goes to the doctor and it's just losing weight, feeling fatigue. There's something, right? So the doctor does a physical examination, assuming that the physical examination is without abnormalities. Then there will be start going a battery of tests. As I mentioned, blood counts are important for the diagnosis of blood cancer because the majority, but not all, the patients with blood cancer will have abnormal blood counts. And depending on the abnormality that you see on the blood counts, you may be able to think of one disease versus the other. If you go to the doctor and your blood counts are very, very, very high, you may be thinking, oh, this patient likely has a form of leukemia. If the patient has very high platelet count, which is a different blood count, which is the one that makes our blood clot, then there may be another form of leukemia. But if the patient has very specific abnormalities in the blood counts, you can actually say just from the blood counts, very likely this patient has something called chronic lymphocytic leukemia, for instance. But blood counts become very, very important. And on patients in which blood counts are not abnormal, at some point in time, very likely the patient will undergo a series of imaging studies, particularly CT scans, in which you will be able to detect masses inside your body, right? You have tumors. Because in that regard, again, it's not that different from other forms of cancer. And if you detect one of these tumors in places where you don't belong, you're going to have to biopsy them, and then you can get the diagnosis. Now, there are other forms of blood cancer that are even less common. There's a disease called multiple myeloma, which there may be about 10,000 new cases in the country every year. Now, 10,000 sounds like a lot, but you need to think there's 10,000 out of 300 million and change living in the US. So it's not an incredibly high number. But multiple myeloma can present with numbness. Multiple myeloma can present with lightheadedness, for instance, or with renal failure. It's a disease that is uncommon, and it has a very odd presentation, or it can present with broken bones. That's a very common presentation. The patient goes to the doctor because having pain out of the blue, they discover that broke some ribs. And when you do the x-rays, there are a lot of changes there that are like, the bones have holes. And this is something that people should not have, right? You don't have holes. Right. So, but that's very specific for myeloma. You usually don't see those things in other blood cancers. So depending on the specific type of disease that a patient has, you may be able to direct your workup. At the end of the day, for the overwhelming majority, you will need tissue diagnosis, which means in plain English, getting a biopsy. People think of biopsies that will require surgery. That's not necessarily the case. You can do a biopsy with a needle, and people usually don't think of this, but biopsy only means that you take a piece of tissue from the body and you run some testing, right? Blood is a tissue, so for some of these diseases, you can get the biopsy, if you will, from the blood.
Blood draw, okay.
Just get a blood draw and do some specific tests. You can perfectly diagnose, for instance, again, going back to the example of the chronic lymphocytic leukemia, you can diagnose it with blood sample, just a blood draw. You don't need to put a needle. You don't need to put a patient under the knife or anything like that. Just a blood draw. Do the right testing, and then you have it.
You have it. Okay, so now we've been diagnosed. So what does treatment look like? What are some of the options for treatment of blood cancer?
Okay, well, so this is the best part of everything. For sure, you never wish anybody to get blood cancer because these are not good diseases to have. But the treatment of blood cancers have changed drastically over the last 30 years. What I learned in medical school is in the history books. It just doesn't work anymore. What I learned during my training doesn't work anymore. So this is an area in which we have been evolving very quickly due to very specific characteristics of the blood. Blood cancers biologically are very different from solid tumors like lung cancer, breast cancer. And you can develop therapies that are very targeted towards the blood cancer, sparing other tissues. So the treatments can be less toxic and can be more effective because they're targeted. Now, this is not necessarily true of every single treatment of every single patient, but you can deliver very targeted therapies that will minimize toxicities and side effects, and be very effective managing the disease. Now, not all blood cancers can be cured, but almost all blood cancers can be treated. And even those that cannot be cured, they can be managed for decades. One of the very first patients that I saw at Hopkins in 2004 was referred to me from a community oncologist because had a specific form of lymphoma. And this patient, the community oncologist had run out of options, so he had nothing else to offer. And the patient recently died of old age. So the fact that I was able to carry him for 20 years and change was just because every time that I was running into trouble, there was a new medication available. And you try it, and then a new medication available, and so on. So the idea is, over the last 2 decades, there are a lot of drugs, new drugs that have come. Now, the treatment for blood cancers, even under the best of circumstances, even with the more modern drugs, carry a series of side effects that have to be discussed with the doctors. Some of the treatments are very toxic. Some others are perhaps less toxic, but all of them have serious side effects. So they need to be administered by somebody who knows what he or she is doing, because the major problem that you have when you are treating a patient like this, once you know what the patient has, is you need to be sure that you don't let the disease kill the patient, and you don't make the patient sick with your treatment.
Right, right.
So you always have to put in the balance a combination between, I want to be as aggressive as I can to put the disease quiet and it's not bothering the patient. But at the same time, I don't want to be the one putting the patient into the hospital because I was too aggressive or I was doing something that, in order to put the disease under control, make the patient ill.
For example, do you have an example of a target therapy? Because I know, like, for me, just in my thought process, non-medical opinion, but when I think of blood cancer, and I think blood is, kind of runs through our whole body, I would assume that chemotherapy would be like the go-to way of treating this, since it's kind of all over the place. So can you explain target therapy and how we're just targeting the blood?
Yes. So we still use a lot of what I like to call classical chemotherapy, which are the drugs that make you very sick and make you lose your hair.
Mhm.
This is natural, this is not chemotherapy. But we still do a lot of that. However, one of the main differences between blood cancers and solid tumors, this is not an absolute, but just to put on your example, is that when we have a patient with a blood cancer, usually all the cells in the tumor will express certain proteins in the surface of the tumor. And these proteins are specific molecules that they just express. They're just putting them in their door, if you will. And the very likely the very first effective targeted therapy that was developed for blood cancer was a medication called rituximab, which is a form of immunotherapy. And this is an infusion that you give to the patient through the vein. And when it gets into the vein and starts swimming in the blood, if you will, has the ability to recognize one of these proteins, couple and attach into this protein, and kill the cell that is expressing the protein.
And it will leave the other, any other.
And does not touch anything else.
Okay.
So now, just as I said, there's no free lunch in life, and these things have side effects, right? So when rituximab is given to a patient, the very first infusion is usually very toxic. The patient gets chills and rigors and is just jumping on the chair. But by the second or third infusion, it's just like they're getting an infusion of water. Like they're watching TV and getting their infusion and nothing. but this drug is very effective killing the lymphoma cells because it's a medication for lymphoma. It has other uses, but mainly lymphoma, and it doesn't affect the other organs. It just goes, attacks the cancer, the cells that express this protein, which are the lymphoma cells, and will kill them. And the side effects, other than the infusional associated side effects, are very, very rare. And it's a very effective. Now, this is just an example of a targeted therapy. There's a similar drug that is used to treat multiple myeloma, again, another form of blood cancer, that attacks a different protein that is also expressed by the cancer cells. And when you get this is not it can be given as an infusion, but it's usually given as a subcutaneous injection. There is an injection under your skin. You get the injection, the medicine goes where it has to go, and it will kill the myeloma. And this drug is perhaps the most effective drug that we have for the treatment of multiple myeloma nowadays. And the side effects are very mild. They're not zero. I don't want to make people believe that, oh, this is like drinking Diet Coke. It's not the case. But certainly the side effects are easy to control for the majority of people. It's very rare that you have to stop these drugs because of intolerance. Whereas if you go to the 1980s, when people were treated for cancer, that was just a house of torture. People were made sick by treatment.
Yeah.
And sometimes you didn't know if it was worse the treatment or the disease. Today we're not there. You can go back to there are other forms of targeted therapy that not necessarily attach the medicine to the surface of the cell to a specific protein, but they block specific pathway of the metabolism of the cancer cell that is more commonly seen on cancer cells than other cells. So they can have other side effects in other organs, but the main side effect is in the cancer cell. So for instance, you can treat a patient with chronic lymphocytic leukemia with pills, and they take the pills at home, and then they go on their merry way and do their life. And the next day they have to take the pill, and you check every couple of months to be sure that the pill is not causing trouble. And if it's not, you just refill the pill, and that's all there is. And I mean, this is to somebody who's been doing this for 20, 30 years, that has nothing to do with what we were doing with chronic lymphocytic leukemia 2 decades ago. 2 decades ago, This was a disease of chemotherapy. You go to the doctor, you get an infusion of chemotherapy every 3 weeks. You lose your hair, you need blood transfusions, you were sick in the hospital with infections. No, now you take your pill. Again, I'm not minimizing the problems or toxicities of the drugs, but this is a very different world, and these pills are very effective.
What about accessibility? Do people, let's say, like that are on like Medicaid or Medicare, do they have a harder time having access to this kinds of treatment, or is this pretty much a generalized accepted treatment option?
Oh no, it's all it will depend on the specific coverage that the patient has, in which they for instance, if they have a Medicare Advantage or some kind of restrictive coverage for outpatient medications, they may say, okay, on this family of drugs, we only cover one. We don't cover the 3 or 4 of them, because there are drugs in which you have 4 of them, and you know that A is perhaps the better tolerated, but Medicare may cover C or D because they're the cheaper. And at the end of the day, they may all be equally effective, but yeah, the side effect profile may be different.
Might be different.
So
I have a couple questions actually about this, about what we're just talking about. Somebody asked, can you explain how exactly immunotherapy works?
Yeah, yeah, we will get there. But let me just finish with the money part.
Sure thing.
This is important. The problem is that depending on also on your coverage, your insurance may say, okay, you're covered for drug A, but you may still be liable for a substantial chunk of cash because these drugs are very expensive. So you may say, the drug is, if you were to pay out of pocket, the drug is $5,000 a month. Depending on your insurance, if your insurance is very good, you may be liable for $50 a month. And if it is not very good, you may still be liable for $2,000 a month. So then when that happens, your doctor needs to start thinking of switching treatments because there are not that many people who can pay just $2,000 a month in a single.
Right. Exactly.
Now, but we almost, all these drugs are FDA approved for a given indication. And once something is FDA approved, very likely the insurance company will cover some of it. Now, going back to the question of immunotherapy, there are different forms of immunotherapy. And all the forms of immunotherapy, at the end of the day, what they do is make your own immune system, the immune system of the patient, attacking the cancer, or involve the immune system attacking the cancer. There are different ways of doing this. One, for instance, is the example that I put a few minutes ago with the rituximab. The protein is expressed on the cell, then it comes the rituximab, which is a form of immunotherapy because it activates the immune system to kill the cell. So it gets coupled with the cell because they have the protein that they're bounding, and then the immune therapy will recognize that coupling and will go and kill the cancer cell. So that's one form of immunotherapy.
Okay.
Another form of immunotherapy is something that it's used a lot in lung cancer. And I have seen tons of commercials on TV for these drugs. And these drugs, what you do is you give an infusion to the patient, and the immune system of the patient goes crazy with excitement. And now I'm perhaps oversimplifying this, but just imagine this is what happens. The immune system gets very active, and the immune system has the ability to recognize the cancer cells as foreign, as bad for you. The thing is, under normal circumstances, you can kill them. But if a patient develops cancer, the immune system is not capable of killing for whatever reason. We don't need to go into that right now. But when you give these drugs, you make the immune system capable of killing these cancer cells again.
Like we supercharge the immune system.
That is correct. That's exactly what happens. You're supercharging the immune system. And these drugs have revolutionized the care of cancer because, you know, when the picture that is on your back was taken and I had hair, lung cancer was, when the disease was spread, it was almost always a death sentence. Today, you can treat people with disseminated lung cancer with these drugs and sometimes get some incredible results in terms of long-term survival, perhaps cure. So that's another form of immunotherapy. There's some other, another form of immunotherapy is, for instance, a bone marrow transplant. If I have a patient with leukemia, which is a form of blood cancer, and I give a transplant from a sibling, for instance, or from a child, well, essentially what I'm doing in a bone marrow transplant is replacing the immune system, the incompetent immune system from the patient with a competent immune system from the donor, and then go and kill the cancer.
So it's funny because there's a question just that asks that exact thing, like, are bone marrow transplants still being used for various blood cancers? Are they still an option?
Yes. Bone marrow transplants are used. The majority of our bone marrow transplants, I'm not going to say just at Hopkins, around the globe are used for the treatment of blood cancers. Not all of them. You can certainly use them for treatment of primary immunodeficiencies. You can use them to cure sickle cell disease or to cure thalassemia. But 99 or 98% of the bone marrow transplants used in the world are for the treatment of blood cancers. And they're very effective. And they're drastically more effective today than what they were 20 or 30 years ago.
So to piggyback off of that, what kind of influences the decision to go the bone marrow transplant? If we're speaking of, you said leukemia is usually that treatment, bone marrow transplant?
Well, so depending on the type of leukemia, but yes. So we have, and by we, I don't mean just Hopkins. These are very much agreed around the world, pathways for the treatment of some diseases. So for instance, for a patient with acute myeloid leukemia, there are different types of acute myeloid leukemias, which again is a cancer of the blood. But for the majority of the cases, it will be agreed that the patient should receive a bone marrow transplant as part of their therapy. For example, okay. For treatments with a different form of leukemia, acute lymphoblastic leukemia, it will be agreed that for the majority of patients, not all, but the majority, there will be a transplant as part of their care. Okay. For patients with chronic lymphocytic leukemia, which we discussed a few minutes ago, incredibly rare that anybody needs a transplant. Very rare. Does it happen? Sure, it does happen, but it's not something that we do now. Because now we're using a different form of immunotherapy for these called CAR T cells,
Right.
which essentially is collecting the T cells of the patient, which is our forms of immune therapy, sending to boot camp, convert them into visions, like literally Rambo on steroids, and then give them back to the patient. And those cells, when they go back, they will go and kill all the cancer cells that they can find. So that's this, but we very rarely do a bone marrow transplant for chronic lymphocytic leukemia today. For lymphomas, there are like 80 different types of lymphomas. Some of them require transplant more often than others. We don't transplant as many lymphomas as we did 20 years ago or 10 years ago, but we still do transplant patients with lymphoma. So for sure, for many of these diseases, blood cancers, bone marrow transplant still is an important part of their therapy.
And when we have a blood, like let's say you do get the bone marrow transplant, I apologize. Is it still coupled with another immunotherapy type, or is it just kind of one immunotherapy and then maybe a different drug?
Oh, no, it can be certainly, depending on, so I'm going to tell you, this may sound like a commercial, but it's not. If you like burgers, you can go to Burger King, you can go to McDonald's, or you can go to a fancy restaurant and get a gourmet Angus burger. And the three of them are burgers at the end of the day.
Yes.
So when we're talking about transplants, pretty much every hospital has their secret sauce and so how they do the transplants. So and depends on the disease and many other factors. So yeah, it's not uncommon that you combine a couple of the strategies to treat a given disease. So for instance, to do a transplant for a patient with lymphoma, you can couple the rituximab that we talk about with a transplant to get better results. For example, for a patient with acute lymphoblastic leukemia, there's also a similar drug like rituximab that is called blinatumomab. It doesn't matter the names, but it works in a similar fashion. Again, protein express, protein couple and then you kill it. But you can combine the transplant with this other form of immunotherapy. So yeah, you can mix and match to come up with these therapies. You can do that, absolutely.
That's good to know. Another question from the chat speaks to his history. So can having a history of hypertension, excuse me, can having a history of hypertension or any chronic cardiovascular condition increase your risk of being diagnosed with blood cancer?
No, I don't think it does. In itself, I don't think it does.
And then the last question that I have for right now in the chat Would asking or seeking certain genetic testing from my doctor reveal my risk level of a certain blood cancer?
Now that we know, um, this is a very difficult question to answer because it depends on what else is happening at that point in time.
Mm,
There is, if you go and you tell your doctor that you want just a panel of genetic testing, my hope is that your doctor will say no. But usually when the patient ends up in front of the genetic expert doing testing, is because something else is going on, right? And then there may be indications for doing a given genetic test. But if you show up just out of the blue and say, I want my genes to be mapped, it's very difficult to know what it means, what you're going to find. Because there are some genes that are associated with certain conditions, but the fact that the patient has those genes does not mean that he or she will develop anything. I don't think that we know enough to really tell that just like as a general screen tool. But if the patient has certain problems and goes to have testing and he or she is found to have certain genes, you may be able to couple the problem with the gene and then, but that is not screening. That's just because the patient had certain problems. You're looking for certain genes.
that makes sense. It gives you something like on the back end, you're having something to actually look for. Trying
That's
to
right.
do it ahead of time, there's really not much to look for.
Yeah.
So we are rounding up on the end of our hour, and I always like to end the conversation with, are there any myths to dispel in the community, us non-medical people? Are there any things that we
Oh,
need to know or we misconceive about blood cancer?
there's one, and it is that it can be cured in many cases. If you start like reading the list of blood cancers that we know, many of them have names that are associated with catastrophes. And again, I don't want to oversimplify this, and I have nothing but respect for the people who have gone through a battle with these diseases and they have succumbed to these problems. So I don't want to minimize anything. But in 2025, many of the patients who have blood cancers will be cured. So people in general need to think of this not as a death sentence. Well, some people die, sure, sometimes happens, but there are many of these diseases that are curable. There are many patients who will be diagnosed with these conditions that will be cured. I have a patient that I also I did a bone marrow transplant around 2005, 2006, something like that. And every year sends me an email on the day of the transplant anniversary, just to say, hey, I'm still here, thank you. And obviously that particular patient's been cured from the disease that had it. And here we are talking almost 20 years out. Every year on the day of the transplant, there's an email. So people can be cured, and it is important to remember that if you go and you seek medical attention and you listen to what your doctors have to say, your chances of having a better outcome are higher. And so the main myth to dispel in oncology is that cancer is a death sentence. It is true for blood cancers or others. Not every patient with cancer will die of cancer. And many patients with cancer will be cured from their cancer.
That's good to know. And I just thought of another quick question. When we talk about getting cured from it, what is the likelihood of somebody having a reoccurrence of blood cancer if they've already had?
Well, yeah, it depends on the specific cancer, right? So, for instance, if I were to meet this evening a patient with newly diagnosed multiple myeloma, I can almost tell the patient that that is not a curable disease. But I can tell that I've known of many patients that died of old age and not of myeloma that live with the disease for years and years and years and years to know it. Okay. I can, if I were to meet somebody with acute myeloid leukemia this evening, and we were to talk about treatment and what to expect, and depending on the type of leukemia, this can be different because not all acute myeloid leukemias are the same. But if just as a general rule, I can say, well, very likely your chance of cure to be alive in free of leukemia a decade from today is about a 50-50. Now you would like to hear is 100%,
Yes.
but 50-50 is drastically better than what it was 20 years ago, right? Okay. If I were to meet somebody with the diffuse large cell lymphoma, which is perhaps one of the most common forms of lymphoma, very likely the chance of the patient being alive and well in 10 years are well over 70% or 80%. If I were to meet somebody with Hodgkin's lymphoma, the probability that that patient will be cured is perhaps over 90%. And so it depends a little bit on the disease, but notice that I'm talking about cures, and 90% cure, it's very high. Now, we all wanted 100, and we're still working towards getting into that goal. But 90% chance of cure on a cancer, I don't think that people realize that that's possible.
Mhm.
And again, yes, the 90% in Hodgkin's is not the same as the 50% in acute myeloid leukemia. But just putting some examples of the fact that these are diseases that can be cured. And yeah, there may be relapses in between. Not always the first treatment is the one that is going to cure the patient. But it is the important thing is not to necessarily think of what's going to happen in the next 6 months, which very likely will be unpleasant. But the important thing is to look into the long term. Okay, so you have Hodgkin's, you have a patient with Hodgkin's, yeah, 90% chance of cure. Okay. It's easier for the patient to think on that than to say, well, you're going to get treatment next 6 months, and some days your scans will look better than others, but
Right.
just think 10 years from today, odds are 90+% that you're going to be cured.
That's a good way to see it. I think that perception of anything that happens in our life plays a major part in our ability to be successful on the other end. And
Yep.
being able to give a positive perspective on a not so positive experience really is a great way to kind of help the mental health of a patient. So I appreciate that tidbit at the end. And I definitely appreciate you for having this conversation. It was very enlightening. I learned a lot more than I thought I was going to learn. I thought I knew some stuff, but I learned a lot more than I thought I would, and I'm very grateful.
We
I
all
look
learn
forward
every
to
day.
sharing this out. So once again, thank you for your time and being able to jump on this call this stormy evening. And thank you for everybody that is on the call. We look forward to next month. Please remember that when you close the chat, there will be a link for you to fill out a survey. We'd love to hear what you have to say about our webinar. And we look forward to seeing everybody next month. Talk to you soon.
Thank you very much.
Bye.